Okay. Hello, everyone. I am Kelsey DeGoo, and I am a senior pharmacist here at the Yorkton Hospital, and I'm also co-chair of our local antimicrobial stewardship committee with Dr. Marcy Hagee as well. So we're based out of Yorkton Hospital, but we do provide information and have some formal policies for Southeast 3 to 5, which would be from Kamsack to Esterhazy area. Today with us, we have two infectious disease pharmacists, Kristin Schmidt and Melissa Kucey, as well as an infectious disease physician, Dr. Alex Wong, here with us today, and they were going to be sharing some information to you guys about antimicrobials and their use in prescribing. So I am going to pass the mic over to them to get started on their presentation. Thanks, guys.
Okay. Thank you very much, Kelsey. Thank you to everybody for attending today's presentation, and thanks again for inviting us here to present. So I'm Mel Kucey. I'm one of the antimicrobial stewardship and infectious disease pharmacists, and I'm joined here by my colleagues, Kristin and Dr. Alex Wong. Kristin and I have had the pleasure of working with Alex for the last 5 years or so, and we work very closely in our clinical practice. And we're very excited to be here today to talk to you guys about antimicrobial stewardship and what that could look like in clinical practice. Okay, before we get started, I'd like to do a quick treaty land acknowledgement and acknowledge that we are gathering on treaties 4 and potentially 2 territory and the homeland of the Dakota, Lakota, and Métis. Recognizing this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples. So for an outline for today's presentation, we're going to look at some of your local prescribing data and review Yorkton's point prevalence study results, which looks at appropriateness of antibiotics. We'll dive into some other antimicrobial use and antimicrobial prescribing. I'm going to discuss a little bit about durations of therapy, and then we'll switch gears and I'll pass it over to Kristin, and she's going to talk to you about urinary tract infections. And then Alex is going to talk a little bit about skin and soft tissue infections and community-acquired pneumonia. We plan on talking for about an hour, so at the end of the presentation, if we don't touch on something that you're interested in or you have further questions about a topic, there'll be plenty of time for questions and discussion, so please feel free to bring those questions forward at the end of the presentation. So I wanted to start off first by talking about why we're here to begin with and why Kristin and I have jobs essentially. And that's really to address the concern of antimicrobial resistance. Now, I think pretty much every clinician has heard of antimicrobial resistance, but I would say that probably most clinicians don't understand the magnitude of this problem. So AMR is a top 10 global health threat identified by the World Health Organization because it leads to longer hospital stays, higher medical costs, and increased mortality. And in 2019, there was roughly 1.3 million deaths directly attributed to antimicrobial resistant infections. And it's estimated that by 2050, so 25 years from now, if we don't change the way we are currently using our antibiotics, we could see as many as 10 million deaths per year due to antimicrobial resistant infections. So to put that into perspective, currently we see about 10 million deaths per year due to cancer. And I think everybody on this call probably knows somebody who's been affected by or who has potentially died from cancer. So if this prediction becomes a reality, well within our lifetime, we'll see as many people potentially dying from antimicrobial resistant infections that we currently see dying from cancer. And that's a very sobering reality. And we're starting to see some of these very resistant infections in our local facilities. These aren't infections that happen kind of across the oceans in Middle Eastern countries. We're seeing these resistant infections in our local facilities. So this is from a patient case that I was involved with. This patient grew a pan-resistant Pseudomonas. It was resistant to every antibiotic we had available to us in Canada. These are very scary scenarios to be a part of, and these are not situations that we want to be involved in because we just don't have any options to treat these patients. And so the previous Assistant Director General of the World Health Organization had said, you know, without urgent coordinated action by many stakeholders, the world is headed for a post-antibiotic era in which common infections and minor injuries, which have been treatable for decades, can once again kill. So this really requires an all-hands-on-deck approach. So what is antimicrobial resistance? Well, it's a naturally occurring process. It happens when bacteria naturally gain mechanisms that protect them from the effects of antibiotics. So imagine that you have a population of dividing bacteria, and at some point during cell division, one of the bacteria undergoes a spontaneous mutation in its DNA that results in antibiotic resistance. Now, when you throw an antibiotic into the mix, an antibiotic is going to kill off all of the susceptible bacteria, and it's going to leave behind that resistant bacteria. And now that bacteria doesn't have any competition, and it can continue to grow and thrive and divide until it forms a whole population of antibiotic-resistant bacteria. Now, the problem is we don't just give antibiotics to people, we also give antibiotics to animals and food-producing crops. And every time we use antibiotics, whether it's appropriate or inappropriate, we are potentially selecting for or creating resistant bacteria. And as the pandemic has shown us, when we're colonized with resistant bacteria, we don't keep our germs to ourselves, we spread our germs. And so if we're colonized with resistant bacteria, we then can spread that to our loved ones, to our family, to our friends, to the environments that we're surrounded in. We can take it to work, to schools, to hospitals, to grocery stores. And then we're further exposed to those resistant bacteria through the foods that we eat, through the waters that we consume. And as you can see, this can spread very, very quickly, and that's why it's such a big problem. So I sometimes think about the effects of antibiotics similar to secondhand smoke, in that when you take an antibiotic, you're not just affecting the health of yourself, but you're potentially affecting the health of the people in the environment around you as well. So what can we do? Well, you don't need to be an infectious disease expert to be an antimicrobial steward. There are very simple stewardship interventions that every clinician can incorporate into their practice to address this problem. Things like shortening durations of therapy, which I'm going to spend some time talking about, using more narrow spectrum antimicrobials, going from IV to oral transitions. These are all things that are fairly straightforward and simple that clinicians can be incorporating into their practice. And I specifically use the term IV to oral transition rather than step down, because sometimes step down to oral antibiotics can be perceived as less effective, when really there's a lot of evidence coming out now showing that oral antibiotics are as effective as IV antibiotics. And so in our clinical practice, we've started transitioning our patients to oral antibiotics, even for our more serious deep-seated infections. So things like osteomyelitis, septic arthritis, empyemas, intra-abdominal abscess. Once the patient is has stabilized and is clinically improved and responded to the IV antibiotics, we'll transition them to oral antibiotics to complete a course or to complete their full duration. So once again, these are things that you guys can be incorporating into your practice as well. So let's look at some of your local prescribing patterns. So a little while back, some of your colleagues had conducted a point prevalence study using a national antimicrobial prescribing survey. And this looks at overall antimicrobial use, and it looks at appropriateness of antimicrobials. And this is a snapshot in time of what the prescribing practices look like within your facility. So you can submit your data to the NAPS program, and then the NAPS program will help you evaluate and analyze your data and send you your data back and show you how your data compares to national data. So super helpful for benchmarking purposes. When you look at Yorkton's data is on the left-hand side, the national data is on the right-hand side. When they conducted this point prevalence study, what they found was that roughly 50% of the antibiotics at the time were completely appropriate. The other roughly 50% were considered inappropriate. And when you look at the inappropriate category, there's suboptimal and then inadequate. So there was about 11% that were considered suboptimal. Examples of this would be using excessively long durations of therapy or unnecessarily broad spectrum antibiotics, or not narrowing therapy when we have susceptibility results back. The other 35% were considered inadequate. So examples of this would be if we had a drug-bug mismatch, if we were using completely the wrong dose to treat an infection, or if patients received surgical prophylaxis beyond 24 hours. And the reason that's considered inadequate is because there's a ton of evidence out there showing that when we extend post-op surgical prophylaxis beyond 24 hours, there's no benefit. All we're doing is increasing patient harm. And actually, the majority of patients that fell in that inadequate category were because they were receiving surgical prophylaxis beyond the 24-hour mark. So when you can look at how your data compares to the national data, it kind of gives you some idea of where you fall and what areas of improvement you might want to focus some of your attention toward. So specifically looking at surgical prophylaxis for giving greater than 24 hours, once again, Yorkton's data is on the left-hand side, national data on the right-hand side. Of the patients who receive, the majority of patients who receive surgical prophylaxis received greater than 24 hours. So 78% of patients got more than 24 hours post-op surgical prophylaxis. If you compare that to national data, that's around 44%. So this definitely indicates that there's an area in which we can maybe make some improvements and focus some of our stewardship interventions towards potentially. Another thing that we looked at very recently was carbapenem use in Saskatchewan ICUs. So there's 9 different ICU sites across the province. And I think what you would expect is maybe for the sites like Saskatoon and Regina, they would probably have the highest carbapenem use because they have the highest acuity of patients. But what we saw was that Yorkton actually uses 30% more carbapenems than the Regina General ICUs. Now, it's important to try and tie this to your antibiogram data. So when we're using carbapenems, we tend to reserve them for resistant gram-negative infections. So whether that's ESBL infections, AMC producing organisms, or resistant Pseudomonas. Now, when you look at Yorkton's antibiogram data, this is from 2023. At the top, there are your gram-negative bacteria, of the most common gram-negative bacteria that you guys culture out in infections that you treat. What you can see across the top is a lot of green boxes. And what that indicates to us is that you really don't have a lot of resistant gram-negatives within your local area. And so we're probably using more carbapenems than we need to be using. And so it's super important to be aware of your local resistance patterns and be aware of your local antibiogram data because it can help guide your empiric therapy. So if you're wanting to know where you can access this, if you go into the former RQHR website, you can access this under microbiology. Under our antimicrobial stewardship website, we also have a link to the antibiogram. And this information is also available on First Line. Now, for those of you who aren't familiar with First Line is a website that you can go to or an app that you can download onto your phone. And it houses local clinical practice infectious diseases guidelines. And it also has all of the provincial antibiogram data on there. So you can have this available at your fingertips, which is super helpful for you for guiding empiric therapy. So for example, if you have a patient coming in with a urosepsis and you suspect it's most likely going to be an E. coli, and you're wanting to know what an appropriate empiric antibiotic option would be until you get your susceptibility results back, you could go onto First Line, click on E. coli, and it will show you the susceptibility patterns for a variety of different antibiotics, and it will help you guide which one would be an appropriate option. Now, you don't have to select an antibiotic that has 100% susceptibility because then we would be choosing carbapenems for virtually all empiric infections, which is not what we want to do because we will further exacerbate the issue of antibiotic resistance. So generally speaking, as long as an antibiotic has at least 80% susceptibility towards a pathogen, then that would give you the green light or the green box and be considered an appropriate empiric option. So I encourage you to check out your local antibiogram and definitely become familiar with this stuff. So we're going to switch gears a little bit and talk about durations of therapy. Now, I want to start by busting this myth that prematurely stopping antibiotics leads to antibiotic resistance. And this was something that was ingrained into my head when I was going to school, in that you absolutely needed to complete your course of antibiotics because if you didn't, you could be contributing to antibiotic resistance. We know now that that's not entirely true. And the fact is that the longer that we take antibiotics, the more likely we are to develop resistance. And so this whole shorter is better has really been the mantra within the ID world for the past few years. There's more and more data and studies coming out showing that shorter durations of antibiotics are as effective as longer durations. And in fact, there's over 130 randomized controlled trials for 22 different infections or conditions, all showing that shorter durations of antibiotics are just as effective as longer durations. So I'm not going to go through all of these, but I've outlined a couple of them. At the top there, you can see community-acquired pneumonia. There are 14 randomized controlled trials showing that a 3 to 5 day course is as effective as a 5 to 14 day course. Ventilator-associated pneumonia, 5 to 8 days of antibiotics, as effective as 10 to 15 days. Intra-abdominal infections, 4 days, as effective as 8 to 10. That's assuming source control has been achieved. Gram-negative bacteremia, 7 days, as effective as 14. And then post-op prophylaxis, there are 55 studies showing that anywhere from no prophylaxis to up to 24 hours is as effective as 1 to 5 days post-op prophylaxis. So a lot of evidence showing us that we can use shorter durations of antibiotics and have similar clinical outcomes. So just to build on this a little bit more, the IDSA had just recently published a community-acquired pneumonia clinical pathway. And for those of you who might not be familiar with IDSA, they publish a lot of infectious disease clinical practice guidelines. It's kind of like the holy grail. We often refer to these practice guidelines very frequently in our clinical practice. So they do have a CAP guideline, but they just recently published a CAP clinical pathway. And within this pathway, they're recommending a 3 to 5 day total duration of antibiotics, assuming that the patient is clinically stable by day 3. And they acknowledge that this is an enhancement to the CAP guidelines. So they're already changing their recommendations to using shorter durations of antibiotics. Ventilator-associated pneumonia, there was a trial that was just published last year showing that for patients who are afebrile and hemodynamically stable off vasopressors, less than 7 days or less of antibiotics is as effective as longer courses of antibiotics. And in fact, some patients within this study received as little as 3 to 5 days of antibiotics for a ventilator-associated pneumonia, and they had similar outcomes to patients who received longer durations of therapy. Surgical prophylaxis, once again, the take-home message here is it might not even be needed, but if you are going to use it, do not exceed 24 hours. And there are some guidelines that they're no longer recommending routine use of post-op surgical prophylaxis. But they say, once again, if you do use it, do not go beyond 24 hours. And the reason for that is there's tons of evidence out there that really there just isn't any additional benefit when you extend the post-op prophylaxis beyond 24 hours. But there is a ton of evidence showing that when we do use antibiotics for surgical prophylaxis beyond 24 hours, all we're doing is increasing harm to our patients. We're increasing the risk of AKIs, we're increasing risk of C. diff infections, and we're not reducing risk of surgical site infections. So all we do is increase harm and we see no benefit. And that's why surgical prophylaxis beyond 24 hours was considered inadequate in that NAPS survey, because there's a ton of evidence telling us that we shouldn't be doing that. So why shorten duration of antibiotics? I mean, I've already alluded to this, but antibiotics are not benign agents. They can cause harm. And in fact, there was a pretty large meta-analysis that was published by a group out in Ontario that kind of looked at all of the evidence out there to estimate the daily harms associated with antibiotic use. So they looked at 35 systematic reviews, over 71 trials. It included over 23,000 patients, and they compiled all this data. And what they found was that each additional day of antibiotic increases the risk of adverse events to the patient by 4%, with a trend of increasing antibiotic-resistant infections. When you look at 5 days of antibiotics versus 3 days, we see an increase in 9% risk of adverse events to the patients. 7 days versus 3 days of antibiotics, 19% increased risk of adverse events to the patients. So shortening your duration of therapy for a patient by 1 to 2 days is not an insignificant thing. If this is something that you incorporated into your practice on a daily basis on a large scale that has better outcomes for your patients and can have significant impact in reducing overall antimicrobial use and reducing antimicrobial resistance. And there are plenty of resources out there to help guide your clinical practice. So I've already mentioned First Line. Once again, it's a website or an app you can download. I encourage that you download it onto your phone. It's a fantastic tool. It has local clinical practice guidelines that myself, Kristin, and an ID physician and pharmacist out in Saskatoon help maintain and create. It has some very helpful resources and tools, and it has all of our provincial antibiogram data on there, so a fantastic resource. We have our SHA Antimicrobial Stewardship Program website that has previous presentations that we've done, so lots of education pieces. Also additional clinical resources and tools to check out. We also have a link to the antibiogram if you want to go there to check it out. And then Bugs and Drugs is also another really great resource that you could use. Also on our antimicrobial stewardship website, we have a document that outlines duration of antibiotic therapy for common infections. So if you want a quick reference guide, because you need to remember how long do I treat a cellulitis for, how long do I treat a community-acquired pneumonia for, you can refer to this document and get a quick answer. This information is also available on First Line as well. So we're going to switch gears now, and I'm going to hand it over to my colleague Kristin, and she's going to talk to you about urinary tract infections.
All right, we'll just roll around here. Thanks, Mel. Okay, so as Mel said, I get to talk about UTIs, which are my absolute favorite type of infection. I only have about 20 minutes, so that's not a lot of time. I'm going to focus specifically on some really common misconceptions that happen around the diagnostics that we use and signs and symptoms and stuff like that. And really the lens that I'm looking at this through is it's for older adults specifically, where the prevalence of UTIs is much higher, as well as the prevalence of asymptomatic bacteriuria. So as I said, this is my favorite type of infection. I think because it's so common, right? One of the top 3 indications for prescribing antibiotics. And we tend to not do that well in using antibiotics for this indication. So often we're using agents that are too broad spectrum, things like fluoroquinolones. We are treating for too long, or we're giving antibiotics when we don't need to. So it's a really crucial area for stewardship intervention. All right, so to highlight, kind of solidify a lot of the concepts that I'm going to talk about, I want to use a patient case to really set the context. So I'll introduce our patient, a 79-year-old woman with a long history of anxiety, presents to the emergency department due to a recent fall, which resulted in an injury. Upon assessment, her lorazepam is held due to concerns that it's contributing to falls. 4 days later, she's brought to her primary care provider's office, so different provider, due to new confusion, akathisia, intermittent physical aggression. So she's broadly investigated with a delirium workup, as we usually do, and often that assessment includes ordering urinalysis and culture, which both come back positive for this patient. She isn't really doing well at home, but nothing else was really found. And because this urine culture is positive, it's decided to treat her with cephalexin. So the next day, she develops a full body rash. Her agitation worsens. She presents again to the emergency department with agitation, palpitations, diaphoresis, hypertension, confusion. While waiting in the ED, she experiences a seizure and is admitted to critical care. Cephalexin is stopped due to concerns of hypersensitivity, and lorazepam is given for suspected benzo withdrawal. And a repeat urine culture is done once again because we love to order urine cultures. And now she's growing E. coli, which is resistant to cephalexin. So we're going to come back to our patient case and talk about some things that might have went wrong. So UTIs, to just define very broadly, kind of 2 categories, uncomplicated and complicated. There's lots of different systems of classification. There isn't really agreement on the definition of all of these, but we're currently waiting for the IDSA to release UTI guidelines, which were supposed to come out in the fall, and we still don't have them. And so I think what I have here on the slide is likely how they're going to reclassify things and really simplify these categories. So uncomplicated UTIs population here would be women and healthy males, and then complicated is basically everyone else. So catheters, any anatomical abnormalities, instrumentation, pyelonephritis, systemic infection, even gram-negative bacteremia to a certain degree would fall into this complicated category. So really the most important point on this slide, which is one of 2 things I hope you takeaway from my 20 minutes here is that a diagnosis of urinary tract infection requires the presence of reliable signs and symptoms. So this is not simply a positive urinalysis or urine culture. Signs and symptoms, I'm sure these common ones you're familiar with here on the slide. So for cystitis, dysuria being the most sensitive symptom, urgency, frequency, suprapubic pain, gross hematuria. And then for complicated UTI, we're looking for those same localizing signs, but as well the systemic ones, which you can see here on the slide. So contrast that now with asymptomatic bacteriuria. So this is isolation of bacteria in a urine culture. So a positive urine culture in the absence of any signs and symptoms. This does not require any treatment. In fact, it actually will do nothing. It's only going to cause harm. So having ASB does not increase risk of mortality. It does not prevent future symptomatic episodes, but it does increase risk of side effects from antibiotics, antibiotic resistance, and actually possibly subsequent infections. So we kind of get ourselves into this vicious circle of giving people antibiotics, wiping out that healthy GU flora, which then can lead to more virulent bacteria getting into the bladder, attaching to those epithelial cells and causing infection. So antibiotics can actually lead to future infections. So important point here, which is sort of a dogma that still exists, but is not actually true, is that the urine is not sterile. So even in somebody who you send a urine culture on and it doesn't grow bacteria, if you do more sensitive molecular testing, you will find that there is bacteria there. And now research is being done into this kind of urine microbiome and what's its role is, and that it likely has some protective effect. The prevalence of asymptomatic bacteriuria depends on the patient population. You can see on the graph there on the right. So it's more prevalent in women. It becomes more prevalent as people age, and it is the most prevalent in residents of long-term care facilities and those with long-term indwelling catheters. So up to 50% of residents in long-term care will have asymptomatic bacteriuria at any given time. And in those with long-term catheters, the prevalence is nearly 100%. So whenever you take a urine culture off of a long-term catheter, you should expect it to be positive, which really drives home the point of doing that assessment and identifying signs and symptoms. The presence of bacteria in the urine does not make a diagnosis of UTI. And the reason why this is such an important area for stewardship intervention is that we're basically always giving antibiotics to treat ASB when we don't need to. I should also mention still two populations where we would give antibiotics for ASB. That's pregnant women and anyone undergoing any genitourinary procedure where there could be mucosal trauma, where you could translocate bacteria. We still give antibiotics for that, but otherwise no indication. When usually about 70 to 90% of the time, though, we are giving antibiotics unnecessarily. So this is just one study that was done in 46 hospitals in Michigan. They looked at nearly 3,000 people with ASB, and about 83% of them received antibiotics. This is a very common stat. You can find hundreds of studies saying the same thing, and we've found the same thing here in Saskatchewan. So lots of room to improve on this. So signs and symptoms which are not indicative of UTI, yet in older adults are some of the most common reasons that we're sending off urine studies like UAs and cultures. If we could stop sending UAs and cultures for the top two alone, we would drastically decrease the amount of unnecessary antibiotics we're using. So foul smelling urine, discolored concentrated urine. If there's no localizing signs of infection, like I talked about before, dysuria, urgency, frequency, these are not indicative of UTI when they're present on their own. Likely it represents dehydration. It could be, metabolic changes. It could be medications, food. So this is kind of like the easiest place to intervene on being stewards of ordering urine cultures. As well, signs and symptoms which do not indicate UTI when they're present on their own, behavioral changes or changes in mental status. This is a tricky topic, which we'll talk a little bit more. Disorientation, falls, decreased appetite. When we don't have localizing signs of infection, these don't warrant an immediate assumptive or presumptive diagnosis of UTI. They're likely caused by something else. So this is exclusive of delirium. So we know delirium carries high rates of morbidity, mortality, infection can be a cause, but not all changes in behavior or changes in mental status are delirium. So whenever we do these education sessions in long-term care facilities, which we do a lot across the province, it's really encouraging people to be adopting use of standardized validated tools to properly assess and identify delirium. So something like the CAM or confusion assessment method, because what we commonly do is any change from baseline is immediately attributed to a possible UTI. When we start ordering UAs and cultures, they're likely to come back positive, and then this kind of closes this diagnostic process and likely will result in not missing the true cause of that change from baseline. So if the urine smells bad, just please stop smelling it. It's the best thing to do. Hand the patient or the resident a glass of water, and hopefully that's going to take care of it. So what about then a change in mental status? How do we approach these patients? We don't know definitively that an increase in confusion or a change in mental status is or is not a sign of urinary tract infection, but we know most often it isn't. So a lot more guidance coming out from experts in this area, which is all kind of saying the same thing, many of these guidelines, in that we need to do a little bit better in our assessment and then in taking this mindful pause and really considering what else could be going on with a patient or a resident. So in someone who presents with a change in mental status, not immediately jumping to presumptive UTI if we don't have the localizing signs of infection, but developing an active monitoring approach. So certainly not sweeping it under the rug and saying that it's nothing, acknowledging that there's a change, but looking for other possible causes, actively monitoring, so maybe vitals more often, reassuring family, residents about this kind of process, that we aren't, we're not just sweeping under the rug what's happening with this resident, but we're going to be a little bit more thoughtful in our approach, not immediately jumping to a diagnosis of UTI and possibly unnecessarily giving antibiotics. So this is a statement from AMI Canada. So again, one of those expert groups that's giving some guidance on how to approach these patients who possibly have asymptomatic bacteriuria, but present with these changes in mental status. So AMI Canada is the Association of Medical Microbiology and Infectious Disease. They have an entire kind of resource package on ASB and UTIs, and they have this statement, which I've kind of highlighted here, the important piece. So in these patients who present with a change from baseline, a change in mental status, who are otherwise stable, so hemodynamically stable, afebrile, doing okay otherwise, let's hold off on assuming a diagnosis of UTI and look for other possible reasons that this could be happening. Dehydration being a really big one, drug interactions, just polypharmacy in general and side effects of medications, sleep disturbance, sensory deprivation, constipation, hypoxia, hypoglycemia. I would add pain to that list as well. Trialing 24 to 48 hours of rehydration, actively monitoring, like I mentioned, doing vitals more frequently. Most often, an alternate explanation can be identified. People will improve with hydration, and then no need to go down this path of ordering urine cultures and those types of things. So I want to talk a little bit more about the diagnostics. I think I've probably driven home this point already, that a positive urine culture does not mean we have infection, but it's so hard for us as healthcare providers to ignore them once they're there. It's such like an ingrained neural pathway that we have. And so really wanting to be stewards of this resource as well, and not ordering urine cultures prematurely or when we might not need them. Another important piece of this is the urinalysis. So this is the second point I hope you take away from my 20 minutes, is a positive urinalysis does not mean that we have a UTI. I always joke that I'm going to get it tattooed on my forehead and walk around the emergency department. I worked in the ER for many years, and I review these patients still, in antimicrobial stewardship, and we just see this documentation so frequently that, patient will present with something unrelated, but a UA is done, it's positive, and then we're saying because of a positive UA, we have a UTI, but it's not the case. So usually we're looking at two different things when we're assessing for infection. So I'll start with the nitrites. So this is a compound produced by gram-negative bacteria only, which are not the only bacteria that we would find in the urine. They have a very poor positive predictive value for infection, less than 50%. So a positive certainly does not mean that we have infection. The negative predictive value is a bit better, still not all that great. We can have false positives and false negatives for a whole host of reasons. So it's really of very little utility. The leukocyte esterase, which would indicate pyuria if it's present, similarly has a very poor positive predictive value, especially in older adults. It's less than 50%, but in older adults, probably even lower than that. So a positive UA or a positive leukocyte esterase does not mean that there's infection. The negative predictive value, though, is much better. It's over 90%, but this is more in younger women and older adults. It's not even this good. So really, this is also of little clinical utility. If anything, a negative UA can help you, or a negative leukocyte esterase can help to rule out infection, but it certainly, a positive does not rule it in. Some studies, like quality improvement studies being done in Toronto right now, which I'm really looking forward to the results of, where they're actually removing UAs from medical directives and order sets in the emergency department for people over 65 because of this exact issue. So let's resolve our case here. So our patient wound up in critical care, eventually is transferred to the medicine ward, where she arrives physically deconditioned, has to spend quite a bit of time in the hospital and then in convalescence in order to regain her baseline function before being discharged home. So lots of things went wrong here for our patient. And so consequences of this kind of reflexive delirium investigations and ordering UAs and cultures and not kind of taking a moment to consider possible other reasons for these kinds of changes in mental status, premature diagnostic closure, which then resulted in missed opportunity for timely, appropriate treatment of what was actually happening for this patient, unnecessary antimicrobial exposure, which led to the development of resistance, led to adverse effects from that antibiotic, other adverse effects, functional decline, seizure, critical care admission. So this is, it represents quite a big change in terms of how we often approach these patients. And I guess I'll take this opportunity to acknowledge that I don't think it's feasible nor reasonable to expect that we can go from giving antibiotics 80 to 90% of the time to treat ASV down to 0. There's still a lot of gray that exists here, but there are plenty of cases where it is straightforward, where we have an alternate explanation, where we're ordering UAs and cultures on stinky, cloudy pee, and it's those places where we can start and really decrease our use of unnecessary antibiotics. So in terms of treatment of UTI, I'm not going to go into specifics here. As Mel talked about, we have guidelines on first line. We recently updated our UTI guideline. We also have a specific UTI and long-term care guideline. So check that out. It will tell you which antibiotics to use first line, second line, all those kinds of things, and how long to treat. So for uncomplicated infection, we're anywhere from 3 to 5 days, depending on the antibiotic. And for complicated infections, catheter-associated, gram-negative bacteremias, pyelonephritis, usually 7 days of antibiotics is enough, assuming we have prompt clinical response. And as Mel talked about, with all of these infections, IV to PO transition is absolutely possible, and possible usually very quickly. So that's all for me. I'm going to pass things over to Alex, and I'll advance your slides for you, Alex.
Thanks, Kristin and Mel and everyone else. And so I see a lot of familiar names on the screen. So I want to thank all of you, whether you're there or not, for actually taking a little bit of time to kind of join us. So I see a lot of physician colleagues. So I'll just start by saying, okay, like here we have pharmacists telling us yet again that we're overprescribing antibiotics. And it's like, come on, man. right? And here's my point. The point is that I work with these two ladies, Mel and Kristin, on a near daily basis, basically, and then when we're in the hospital together, like on a daily basis. And essentially, I have been able to shift my practice over the course of several years from a point where I was just kind of doing old school 4 to 6 weeks IV on everybody, just overprescribing kind of across the board. Still probably doing better than a lot of generalists, but not doing great, to a point where I am doing IV to PO transition within like a couple of weeks, down to oral. A lot of you have spoken with me on the phone about things like osteos, septic arthritises, all this type of jazz, where there's appropriate source control, where the person is getting better clinically. And we're talking about basically doing 2 weeks. I kind of call it 2 weeks of IV induction therapy, essentially to really get that patient into a better place. And then if they're healing, doing well clinically, everything's reassuring from the clinical perspective and, the lab perspective as well, then doing an IV to PO transition at that point in time. And, the amount of IV antibiotics, even in the last 2 weeks of service that I've been able to save by not just auto killing everyone with 4 to 6 weeks is dramatic. And again, some of you may know I was in the hospital. I had a severe, like, invasive group A strep. And even with my own infection, I literally gave myself like 11 days of antibiotic total. So in the end, like, all of this is not bunk, I guess is what I'm trying to say. Okay, all of the literature in the space is moving towards shorter durations, shorter courses of therapy, more oral antibiotics, and more IV to PO transition more quickly. And here's my practical tip for all of you, because again, you're looking at me, and I think many of you I've talked to on the phone when I'm on service and stuff, and I try as much as I can to be helpful. But we all have these kind of like ingrained things around durations, which is all based on this artificial Roman calendar system that we have, right? So it's like 3, 5, 7, 10, 14, 21, 28, et cetera, right? So here's my challenge to all of you, like in the generalist space, because you're all in the emergency departments, you're all in the hospital, right? You're dealing with this stuff every single day. Take whatever your gut response is with regards to, okay, you see a cellulitis, in the emerge, and your gut response is, say, 10 days IVPO total, for example. Just take that 10-day and drop it from whatever the notch is down one notch. So if it's like 10, go to 7. If it's like 7, go to 5. If it's like 14, go to 10. Okay. Not a huge change, just a little change. Okay. And what you'll find, I promise, is that the patients will be completely fine. The patients will be completely fine. They'll do fine clinically, and you're going to give way less antibiotics. And that is going to be a good thing for everybody. Okay. So I just want to really drive that point home, that even for me as an old dinosaur, I've been kind of doing this now kind of like 15 years, for example. It was hard to go from like, doing 6 weeks IV for every empyema, every osteo, and so on and so forth. But I'm on the train now, and now, again, I'm seeing patients 2, 3 weeks post, like in clinic, in the hospital, whatever the case may be, or asking my colleagues to do so. And then from there, if everything is good, they're clinically doing better, labs are good, everything's going well, that's going to be that transition point, right? And I would think over time, as we continue to adopt this, I'm kind of driving this in to my internal medicine colleagues, my hospitalist colleagues, and so on and so forth. We're going to hopefully see a significant improvement in terms of lengths of stay, overall outcomes, rates of C. diff, other complications, et cetera, et cetera, et cetera. Okay. Can you advance, please, Kristin? Hang on a sec. My kid is, Daddy's just giving a presentation. I'm going to be done in about 30 minutes. Okay. I got to ignore my daughter here. She's looking for the iPad. And she's angry. So we're going to start by talking a little bit about skin and soft tissue infections first. And this is just a very generic case. Some of you that have done SIPA or have done teaching in the past will have heard this. 33-year-old fellow, otherwise healthy, no meds, comes in with a red, hot, swollen left leg. He presented previously to a walk-in setting, and he got cephalexin 504 times a day for like 5 doses, didn't get better. Pain is worse now. He's not systemically unwell or any fevers or anything like that. He's not toxic. So how do you manage this? So again, we don't have a lot of time. So, when I'm teaching anyone, whether it's like learners, whether it's colleagues and all the rest of it, what are we sort of thinking about? The first question we always ask is it an infection or not? And what are the potential mimics of a unilateral swollen left leg? And you can think about all of those things, ranging from like DVT to like stasis dermatitis to lymphedema to all those other things. Let's assume in this situation it's a legit skin and soft tissue infection. Do you need to do lab investigations? Do you need to do imaging investigations or not? And again, that depends on whether or not there's any other like features at play. In this situation, young, otherwise healthy, no medical problems, no underlying hardware, no previous like orthopedic manipulation of any sort. I would say that there's basically no role here for any routine lab work, blood cultures, x-rays, anything of this sort. CRPs as well, like for Christ's sake, it's like a cellulitis. You don't need a CRP of 63.4 to confirm that for you, right? So then from there, the question becomes like oral antibiotics versus IV antibiotics. And the fundamental difference in some classes of antibiotics between IV and PO is essentially bioavailability. And remember that there are classes of antibiotics, for example, things like quinolones, cotrimoxazole or Septra, TMP-SMX, tetracyclines. I'm going to say clindamycin, but I think many of you know I really do not like clindamycin as an antibiotic. And things like metronidazole, for example, all of these have like very, very high oral bioavailability, meaning that you essentially can use it in an oral form, and the level or the amount that gets into your blood and subsequently gets into that affected body site is going to be equivalent to basically if you were to give it through IV. Now, some of the main classes that we use, like beta-lactams, for example, there is a difference, but the difference is not as dramatic as we necessarily think in the end. And so in this sort of situation, the guy's getting worse with oral antibiotics, probably needs IV, but that's a clinical decision depending on the extent of the skin and soft tissue process, what he's previously been on, whether he's toxic and so forth. Okay. So in this generic situation, I'd be looking at doing probably 2 to 3 days of IV with a beta-lactam, either cefazolin like with probenecid or just cefazolin 3 times a day, or ceftriaxone once a day if you don't have probenecid available. The key thing being here, and do I have my purulent versus non-purulent? I think that's coming up, right? Okay, Kristin just nodded. Okay, so here are some like pearls that I have. I am like, it's kind of sad because we rely so little on physical exam at this point in time. Like the only thing that actually makes me feel like a real doctor at this point is managing skin and soft tissue infections, where I can go, look, examine, feel the patient in terms of like what's actually kind of going on, do a proper exam, and actually make a diagnosis. So if you see any streaking lymphangitis from the location of your skin soft tissue process to essentially like a proximal node. So if it's your upper extremity, you're getting like some kind of streaking lymphangitis basically to the axilla. Similarly, if they have painful tender inguinal nodes, or you see like streaking lymphangitis up into the inguinal region unilaterally, that is classic group A strep. So the two things I'm going to do when I see like a cellulitis or non-purulent cellulitis, especially because that's very typically a beta hemolytic strep, is I'm going to basically check the proximal lymph nodes, whether that's the axilla, whether that's the inguinal nodes, and if they have tender proximal lymphadenopathy, that's classic group A strep, then I'm using like beta-lactam up front, and I'm probably stepping them down to like amoxicillin, post. I'm not even using a cephalosporin in that situation. Okay, that's classic group A strep. And of course, all beta hemolytic strep are exquisitely beta-lactam susceptible, penicillin susceptible. Whenever I see bilateral cellulitis, that's always a bit of a flag. More often than not, that's usually like a stasis dermatitis type thing. And then think about like if you've given appropriate antibiotics, this happens a lot, and they don't improve, you need to start thinking about non-infectious mimics, right? So things like Charcot, stasis dermatitis, gout, and so on and so forth. And then neck fash is uncommon, okay? But the hallmark of neck fash is pain out of proportion, and a lot of people get group A strep sort of confused with neck fash because a lot of the beta hemolytic strep, particularly group A strep, can cause a lot of this kind of superficial kind of hemorrhagic type change, which looks horrible. I had that on my abdominal wall. It looked horrible, but in the end, it wasn't a neck fash, right? And so again, you don't expect everything to get to normal in 5 to 7 days, right? Like you're dealing with the remnants of damaged skin and soft tissue. Just because it doesn't look normal and you're dealing with all that sort of superficial transformation doesn't mean you have to carry on with the antibiotics. Next. Next. Oh yeah, here they are. So yeah, at the end of the day, this is a clinical diagnosis. No labs are needed. I really would generally avoid doing things like CBCs, CRPs, and so forth. And I've kind of spoken to a lot about all of this already. So we'll just move to the next slide, I think, which is kind of the main sort of teaching point here. So when I teach learners and I'm thinking about decision points in terms of how to manage and how to empirically treat a skin soft tissue process, really the key thing is it purulent or is it non-purulent? This is assuming that it is a skin and soft tissue infection, okay? Non-purulent cellulitis 90% plus of the time is going to be beta hemolytic strep. So what that practically means is that you can use a beta-lactam, specifically a cephalosporin, in that situation and cover it probably well over like 95% of the time. Okay. Of course, if somebody is toxic, not doing well, needing to go to the ICU in septic shock, that's a little bit different. Then you need to sort of think about other things. But in general, you have a non-purulent, uncomplicated cellulitis like this case. For example, that's going to be cefazolin plus probenecid, ceftriaxone. And then from there, it's going to be stepped down to oral, probably cephalosporin within 2, 3, 4 days once they have good clinical improvement. And probably doing no more, as I said, than 5 to 7 days total. Okay, so the difference is that if you have pus, purulent cellulitis, like an abscess with a skin and soft tissue component, or just a straight abscess, once you get pus, then the likelihood of Staph aureus increases significantly. And the problem in Saskatchewan, in most parts of Saskatchewan, not all, but in your guys' area across the board, like in the former Sunrise Health region, we have a high proportion of Staph aureus isolates that are methicillin resistant. So it's probably somewhere, I don't know what right off the top, but we're probably looking at like somewhere between 30 to 40% of all the Staph aureus isolates in Regina, in former Sunrise, for example, that are going to be MRSA. And so you need to at least think about MRSA in that context when you have pus. That being said, there's good data that shows that if you have a drainable abscess, no significant skin soft tissue components, you just drain it. You don't need any antibiotic at all. Most of us would give a short course. I wouldn't advise doing like more than say 3 days of Septra, for example, in a situation like that. Otherwise, when you get your cultures, like when you drain, you always are going to be able to get your cultures, right? So you can then sort of tailor your therapy from there. And in that sort of situation, I'm probably going with something like TMPS-MX or Septra, which has good Staph aureus coverage, not quite as good as Doxy, but not bad. But it's also going to give you like reasonable beta hemolytic strep coverage compared to Doxy, which doesn't cover beta hemolytic strep well. So, you can cover something with, say, 5 days of TMPS-MX, DS, one tap POBID, for example, and that should cover everything you need to cover. Okay, next slide, please. I kind of talked a lot about this already, and I'm not going to get into it in great detail, but these are like some of the worst ID consults that I get, like where, for example, so again, it's kind of ingrained in nursing school that the moment you see a skin soft tissue infection, that they draw the border, right? They draw the border. And then like a day or two later, you know what, like most of the time, like probably 80-90% of the time, the cellulitis don't just magically recede instantly the moment that you start receiving IV antibiotics. Like there is a worsening process. And so and then what happens is that things kind of worsen, then it kind of steadies out, and then it kind of plateaus, and then it starts to get better, and then it starts to get better fast. And all of you know what I'm talking about in terms of an uncomplicated resolving uncomplicated infection like a cellulitis or pneumonia or anything along those lines, right? So basically, it's normal to have some degree of progression. And so when you go in at 24 hours and you see that your cellulitis has advanced like 1 or 2 centimeters past the border, that does not mean that your antibiotic is failing. That's just part of the normal process, right? And I get tons of consults where it's like, okay, so they see this, they freak, and then it's like DC, cefazolin, piptazo vanco, or piptazo, or whatever, or ceftriaxone vanco, and consult ID. right? And then I come and I kind of do my little internal eye roll and I'm like, DC everything that just happened and put back cefazolin. Okay, that's like an auto consult for me. So, and stewardship pharmacists like Mel and Kristin, they just kind of roll their eyes too, right? So it's the same sort of thing. We do this all the time. So I'm trying to teach again, and we're trying to just give your cefazolin like a couple of days, okay? Like let it work. Give it 2 or 3 days, and you're going to see the improvement clinically. The golden rule with a skin soft tissue infection is that the systemic stuff always gets better before the local skin stuff does. So when I go in, and again, I'm not usually managing an uncomplicated SSTI, but if I was, or if I had an OPAT and I was actually just seeing patients in OPAT, the golden question that I would ask that patient, even I am not looking at the leg or the limb or the arm or the cellulitic area. The first thing I'm asking is think about how you felt like 2 days ago when you first came in before you started your antibiotics. How do you feel now compared to then? Okay, and maybe you're seeing them at 48 hours post, maybe you're seeing them at 72 hours post, but commonly what you're going to hear is, you know what, like the leg, abdominal wall, arm, whatever, still really hurts, but I feel better. And then I usually will ask, like, how do you feel better? It's like, okay, well, I don't have those shakes and fevers and chills anymore. Or, you know, my appetite's back, or I have more energy now, right? All of these systemic pieces tell you that your antibiotics are working. Okay. And then you look at the leg and you see, OMG, like cellulitis is advanced like 1 centimeter past the border that your blessed ER nurse drew like 2 days ago. That does not mean that your antibiotic is failing. That is normal process. Carry on. Okay. Carry on. Okay. Next slide, please. And so really, I mean, the way that I kind of teach it is when they're on that steep curve of improvement, whatever that looks like, right? Whether you're dealing with an uncomplicated pneumonia, whether you're dealing with like gram-negative sepsis, where they're turning the corner relatively quickly within like 48 hours, or, you know, again, like whether or not they're improving from the SSTI perspective, that's when you're looking to do your oral step down. And that's really my main thing. And so what do you step down to? Cephalosporin, you're probably stepping down to something like cephalexin. You know, if they're on Vanco up front, then you're kind of just stepping down to Septra, like I said. Or if they've got like a Septra or sulfa intolerance, then maybe you're doing a combination of like Amox plus Doxy, for example. The Amox gives you your beta hemolytic strep coverage, and then your Doxy gives you your staph coverage, both for MSSA and MRSA. Total duration 5 days, if uncomplicated with clinical improvement. If not, maybe a touch longer, 7 days. Okay, carry on. So yeah, back to the case. Remember the golden rule. And in this sort of situation, like as I say, I'd probably put him on just cefazolin. Like if he's not over like 80, 90 kilos, probably just a gram Q8, and just give like 2, 3 days. And once he's better clinically, then it's kind of step down to cephalexin or something like that to finish the course total. And that's it. Next slide, please. Now I'm over time because I knew I was going to be, but I'm just going to carry on. So for community-acquired pneumonia, again, we see 1 billion of these, right? And what are you kind of doing up front? So I'm not going to lie, I'm not doing a curve 65, but you should do a curve 65. That is per guidance, okay? And if they have a score of 0, they're otherwise healthy, you're really looking at short course, either Amox or Doxy, and done. My bias has always been, although there is no evidence to support this, so again, just for clarity, there's no clear data that shows that empirically treating atypical organisms in the context of an uncomplicated community-acquired pneumonia improves outcomes in any way. So I always had this bias of wanting to cover atypicals because I know, we all know how many community-acquired pneumonias are caused by atypical organisms. And for those that don't remember what atypical organisms are, these are all those so-called non-gram stainable things like Chlamydophila, Mycoplasma, Legionella, all this type of stuff. There's no data that shows that empirically treating those actually makes any practical difference. So just doing a straight beta-lactam like Amox, high dose Amox like a gram POTID for 5 days is adequate. My bias is probably to use something like Doxy because Doxy provides me. So, you know, the classes of antibiotics that provide atypical coverage are things like tetracyclines, quinolones, and macrolides. I notice that none of those, other than for Doxy, are considered first line. Quinolones in general are just completely out of fashion and out of favor at this point in time, due to the fact that we just have a much better understanding of like significant AE profiles in terms of neurologic related complications with like neuropathy and so forth. And then like the musculoskeletal stuff that I think we're all familiar with, like the tendinopathies and so forth. Then there's an association now with things like aortic aneurysms and aneurysm rupture and so forth. So I'm not gonna lie, levofloxacin used to be like my favorite antibiotic, and now sadly it's not even like on the top 10, sadly. Again, I mean, we can all change, even dinosaurs like me at the end of the day. So if they have a curve of 1 or they have comorbidities or recent antibiotics, then your risk of having more antibiotic resistant organisms grows. And that becomes a situation where you're looking at doing like a more aggressive course with something like clavulin for 3 to 5 days, and you're adding your macrolide for atypical coverage at that point. And the typical dosing that we're using in terms of short course is high dose azithromycin 500 Q daily for 3 days. And you could do this in the hospital as well, right? So, you know, for your typical like person coming in sick onto the ward with lots of comorbidities and has been on antibiotics in the past, maybe you're starting with something like ceftriaxone and azithro. You write your azithro 500 PO Q daily for 3 days. Again, remember that the bioavailability is almost identical to PO to IV. And then you're starting with ceftriaxone like a gram in most individuals, 80 to 100 kilos. Maybe you want to bump it, but for the most part, you're doing a gram. And when they're better, you can do oral step down to probably something like cefuroxime 500 BID to finish like a 5-day course. Okay. And we're seeing more and more of that being done in Regina, which is heartening. And they do absolutely fine. Next slide, please. So yeah, I don't really have too much else really to say. It gets a bit more complicated when they have Pseudomonas, or when they're colonized with Pseudomonas, or when they have risk factors for Pseudomonas. Similarly, risk factors for MRSA, or if they're dying, you know, in septic. That's when you're kind of just, okay, here's your Vanco, here's your, you know, Piptazo, for example, and then out the door they go, kind of thing. Notice how, again, in all of these sorts of situations, there is no role up front for using like a carbapenem up front in any way. And the practical benefit you get from giving Piptazo in this type of situation outside of pseudomonal coverage versus doing something like ceftriaxone metronidazole is truly minimal. Okay, so at the end of the day, just de-intensify and use less, and you'll find that the patients do just fine. Next slide. I don't have too much else to really say, right? So again, I mean, I don't know what all the clinicians are thinking. I mean, hopefully you guys weren't like eye rolling here as Mel and Kristin, you know, were kind of going on, but everything they say is just utter truth at the end of the day. And I mean, there's a bit of a joke, right? At the end, I mean, my life is completely run by women in the hospital and at home. Like basically I'm married to a nurse. I have nurses all around me in my clinic. They just tell me what to do, and even the admins and so forth, they just tell me what to do and I just do it. But when I'm in the hospital, it's funny because so many people are like scared of me for whatever reason, probably because I'm super intense at times. But like when Mel and Kristin just kind of give me the glare, and it's like, okay, I can't write ertapenem here. I got to do ceftriaxone metronidazole. Okay, so it's like, okay, I'm scared of them. So, and in the end, you know what? Guess what? It actually works. Like the patients don't die, and we see the sickest patients. Like we see the conglomerate of everything that comes from across southern Saskatchewan, right? And we're able to step them down, and they're able to do just fine. This isn't always the case, but probably like 95% plus of the time, that's the case. And again, you'll see when we are discharging clients in patients and transferring them back out, you're going to see more and more of this. This person's got osteo, for example. We just did 2 weeks IV. Now they're on 4 weeks PO, for example, and no ID follow-up needed, for example. Okay. And no more labs, no more stupid PICC lines, no more home IV, no more having to be like trapped in an institution because you need your Piptazo, you know, 3-4 times a day or something like that. And you're going to see more and more of that. And we would really encourage all of you to adopt similar practice because it is the right thing to do. Okay, we'll leave it at that. Questions? Or Kelsey, do you want to moderate?
Just gonna look at the chat box quickly. There was just one question that said, recently had an OBGYN tell a patient that it is not necessary to treat ASB in pregnancy in low risk patients as a question. Any
That's
comments
very
to it?
exciting. Yeah, that's fantastic. So some countries, European countries, this is now the recommendation is that only the highest risk pregnant females actually need ASB treatment. It's not widespread practice yet, but I would not discourage it. Yeah. We just don't really have evidence to the contrary at this point. It's not that there's evidence that there's harm if you don't do it necessarily. So I go for it.
If we can then just take like 1 minute, can you pop the slides? Whoever is in charge, can we just pop the slides back up real quick and just go back to the antibiogram? And I'll just point out a couple of like just practical points with regards to just the antibiogram. And I see a couple of other questions popping up here as well. So let me just kind of go to your guys' antibiogram, knowing like I see some peeps from kind of Weyburn, Moosomin kind of area, and your guys' antibiogram might look a tiny bit different than this, but you know, again, I mean, I would strongly recommend that you download the various apps and software pieces that were recommended by Kristin and Mel. But if all you do is you just get a PDF of this and you just put it somewhere on your phone where you can access it relatively easily, then that in and of itself is good enough. Let me just kind of point everybody really quickly just to the gram-negative section, looking specifically at E. coli, which is by far and away the most common cause of like UTIs in general. I just want to highlight two things. One is that Cipro 74, and given the fact that quinolones are totally out of favor, you should never be prescribing quinolone in the setting of an uncomplicated UTI ever. Secondly, when you look at nitrofurantoin, specifically in the urine, because it concentrates in the urine and it's not systemically bioavailable, you see 98. That's a reasonably high number. Even my parents would have been happy with that in high school. So versus 80, which is like TMPSMX, which is right next to the nitro. So 98 versus 80. So again, if you look in the first line guidance, and I don't know what the app says, like for the Yorkton area, I'm guessing it's probably going to say like TMPSMX DS, like 1-tap POBID for 3 days, or nitro 100 milligrams POBID for 5 days. Either is fine. In this sort of situation, I'm still probably leaning towards nitro because it's 98. Plus, there's no systemic bioavailability. There's basically like limited to no normal flora, gut flora alteration, and that's going to reduce your risk of complications, C. diff, and so on and so forth. So that's one thing that I would point out. The only other thing, and Cipro 74 anyways, for what it's worth. The last thing that I would just say and that we point out, which Kristin and Mel already pointed out, was that your ceftriaxone is 91 in this situation. Your piptazo is 95 and your ertapenem/meropenem is 100. So for practical purposes, like the actual, and this is all isolates, right? So the majority of these E. coli isolates are almost assuredly coming from the urine. So if you actually look at sterile sites, like from blood or mostly from blood, I'm guessing in this sort of situation, like the number is minimal. Oh, actually it's right down there. Yeah, like the N is 20. So there's only 20 isolates that were actually ESBL positive. So the actual benefit that you get from going, say, from ceftriaxone to Miro or from piptazo to Miro is really minimal at the end of the day. So I'm not questioning if you want to throw piptazo in the mix up front, although I would strongly question the value of carbapenem right up front. Again, for most situations, if you have someone that comes in florid sepsis, you're almost assuredly going to get a positive blood culture back. And once you get that positive blood culture back and they're doing better on their piptazo, then you absolutely should be stepping down to something that's far more narrow, whether that's like cefazolin for another 2-3 days, or just getting them onto oral with something like TMPSMX. That is totally reasonable, you know. And then I usually like to repeat the cultures in that situation from the bacteremia perspective, make sure they clear the bacteremia quickly, and then that's a 7-day total uncomplicated gram-negative bacteremia type of situation, okay? And we see that like all the time. So like if they end up coming in on Pip/Tazo, then you drop them to, I don't know, Cefazolin for like a day or two, and then you drop them from there to like TMP, SMX, DS, one tap POBID to finish the last 3 days. Like that would be like absolutely optimal prescribing. Okay, optimal prescribing. Okay, those are just some random points. I think there were some chat questions as well.
There's a few more here. The next one is, did I hear that Septra has better strep coverage than doxycycline?
It does. It has better beta hemolytic strep coverage in general. We do not rely empirically on doxy or any tetracycline for beta hemolytic strep coverage, which is why I'm uncomfortable using it on its own for an empiric kind of skin soft tissue thing, even a non-purulent, especially a non-purulent one. In a purulent type situation, again, you're going to get cultures and you're going to know what it is you're dealing with. But when you don't have cultures, I still kind of prefer amoxdoxy if you need to go that route, or just use straight Septra, which provides both reasonable MSSA, MRSA coverage, as well as beta hemolytic strep coverage. And to be fair, I had to relearn this like probably 6 years ago, because I was always taught as an ID fellow back in Edmonton, like 2008 through 2010, that Septra had crap beta hemolytic strep coverage, and that's incorrect. That is wrong. Okay, so use Septra in this type of situation as a nice step down option, which covers pretty much all your gram positives well.
And next question was, can you provide your duration length recommendations and antibiotic preferences for osteomyelitis?
Who asked that, just out of curiosity?
Cara Fallis.
Cara Fallis. Oh, yes. I'm excited to I'm trying to get my way out to Mooseman, Cara, so I'm hoping to have a chance to meet you in person at some point. But
we would love that. Thank you.
Yeah, but the short answer here, I think we've talked a couple times on the phone, right? So it really kind of depends. Like if for example, you have a situation where a client's got like an ulcer that requires debridement, and it's debrided, and you get a wound swab and it shows whatever, like GI flora, for example. And when they come in, it's kind of just stinking up your whole ER. Then that's probably going to be like a gram neg anaerobe. I'm kind of probably starting with something like ceftriaxone metro in that setting. And I'm using like the higher dose ceftriaxone for bone involvement, like 2 grams, and then metronidazole, like 500 BID. And then from there, once they have appropriate debridement, everything's kind of getting better. I'm usually looking at no more than probably a couple weeks kind of post debridement. And if they're doing well clinically, they're improving clinically, and everything's healing nicely, the wound is clean, there's no evidence of uncontrolled infection, then I'm dropping them at that point to probably 4 weeks of something like cephalexin metro PO. And that's it. Like, I'm not even following those folks up at this point, kind of once they're doing better at the 3 week mark. They're transitioning and their PICC lines are coming out, and I'm not even bothering with like any more lab work or anything like that in a situation where that person's doing well clinically. It's a bit more tricky when they're not surgically debrided. For example, if you just have like a big swollen toe, where there's like some nasty ingrown toenail or something, and you take an x-ray and like the top of the toe is like gone, right? So then it's kind of like, what do you do? That's a situation where clinically it's a little bit harder to follow, and I'm still following them pretty closely clinically. Maybe I'm kind of going a little bit longer orally, or sorry, IV in that type of situation. Similarly, like again, if there's no like overt source control that happens, it's a little bit harder to do that easy kind of IV to PO transition. But again, similarly, if you have a septic arthritis, the vast majority of septic arthritis, like legit bacterial septic arthritises, should be debrided, right? So after debridement, I'm looking at 10 to 14 days total IV. Again, there's data supporting that you could even stop at that point and outcomes would be reasonable. I haven't gotten to that point in my practice yet, but I'm usually doing like short course, 10 to 14 days post debridement, and then dropping oral from there if they're doing well clinically, which is better than auto 4 weeks or auto 6 weeks, which, to be frank, like some of my colleagues are still doing. Okay, so we're all in different stages of change. But that would be my generic approach. And I get tons of calls from a lot of you in sort of like the periphery and rural with regards to, osteos of, and again, we don't have like a super high functioning foot clinic right now in Regina. Peter Chang retired, and that took away a lot of capacity, like from the foot clinic perspective. There are plans to try to fix that, but it's kind of a work in progress at this stage. So a lot of folks, across southern Saskatchewan who had access to the foot clinic, it's a bit more of a struggle now. But in general, that would be my approach. Like when you're looking at a diabetic foot or a poorly vascularized foot, I'm usually asking three things. I'm asking, like, does it need to be debrided, like locally? Do they have appropriate vascular supply? And what antibiotics are necessary? And it's got to be a combination of all three of those things managed together that provide you with an optimal outcome. So if you just debride someone, but they have no vascular supply, all you've done is left them with a larger wound that's not going to heal. So, and if they have vascular supply, but they need debridement, then local debridement should be sufficient with appropriate wound management. And that would be the kind of situation where you could look at stepping down relatively quickly. Okay, so these are just some high level tips. And a lot of the times when I'm on service and you guys are calling me, I'm usually just asking for de-identified pictures of whatever it is you're talking about so that I can provide some guidance, right? I just did this for like a couple of clients yesterday, as a matter of fact. Hope that helps.
And the final question in the chat box is any tips or tricks on how to move our providers on these practice changes?
I mean, change is an iterative process. That goes without saying. So again, I would just highlight for those listening again, like including especially the providers, the clinicians, the prescribers, just do my little trick of like take your gut feel of what it is that you're going to prescribe up front and just drop it down from your arbitrary Roman calendar choice to like the next lowest Roman calendar choice and just try it. I swear to you, everything will be completely fine. Okay. So, like I say, like 14 days go to 10, 10 days go to 7, 7 days go to 5, 5 days maybe go to 3. That's a little bit more dicey. Okay. Maybe just stick with like 14 to 10, 10 to 7, 7 to 5 for pretty much everything you're doing. And what you'll find is that the patients will do completely fine. Okay. And if you need a little bit of additional encouragement, rely on your pharmacists. Your pharmacists, as much as I occasionally get grief from the pharmacists, I mean, they know what they're doing. And they're not trying to be pains in your whats. Like they know what they're doing. And we all are overprescribing in general. Too broad, too long. And we would all do better to de-intensify more quickly across the board. And that's where the literature is headed. So I don't know how else to really say it as clearly as possible. And I am sort of living proof that even a dinosaur like me can change, over time. And I can attest to all of you as clinicians that it creates better outcomes for clients across the board. So in summary, less IV, more IV to PO transition, shorter durations, less broad therapy. Take your Piptazo Vanco, for example, and just stop. Like just do Piptazo only, leave the Vanco out. Or take your Piptazo and just do ceftriaxone metronidazole. That's a relatively simple transition, but in the end, like when you look at your antibiogram and you look at the stuff we're dealing with, like you're losing practically nothing, in the space, like when you do those types of things. And then again, think about doing quick IV to PO transitions. And again, if you need a bit of help, call me, call whoever's on call, like from my colleague perspective, and you'll find that this really improves practice and improves patient outcomes. And we'll come and nag you guys at some point down the road as well.
Thanks, Alex. Really feeling the love from you. Thanks. I would just add, like, we're more than happy to meet with your stewardship committee and really like dig into the particular issues that you're finding and see if there's some intervention that we could implement. So, we're doing MRSA nasal swabs here in ICU. Like it's easily something you guys could implement there, but audit and feedback, like I put in the chat, is a really effective thing, but you need the data. So, I mean, the point prevalence survey is a start, but even simple things like in our ER, so in the ED MD assessment tool, which I think you guys probably do something similar, we've just added an additional piece of, did you prescribe an antibiotic to this patient? Yes or no? And then was the indication one of these top 3, right? So skin, soft tissue, UTI, pneumonia, inpatient or outpatient? What did you prescribe and how long? And then that gives us a perfect glimpse. Like we can pull that data in our ER, and we saw that we were on average for outpatient cap giving 7 days, which we don't need to. We can give 5. So then we could go back to the ER group and show them their data. You know, can't argue with that. And then over time, we can see if that changes. So those are some relatively simple things that you can be doing. We're happy to help with that.
It's like just a couple more comments, not questions, but Kara said downloaded the first year residency. It's the best. Thank you. Tanya said we want you to come and nag us with a smiley face. And Kendra says thank you. This was excellent. We really appreciate the support from Mel and Kristin and the ID docs.
So I don't know.
Oh, sorry. Go ahead.
Yeah, I don't know how you guys are going to distribute the video. I'm assuming you're going to put it like on the internet somewhere and just kind of upload it or put it like as an internal link. I would just suggest you just, when you do that, if you're going to send something out by email, just send out like the PDF of the antibiogram and then send out like, just send out details of how to download like the First Line app as well. And then like put all of that in one place, like somewhere on the internet. And then honestly, we will probably point our providers to the same locations, right? And just as a place where, because all of this is obviously applicable not just to Yorkton, but to everywhere across the province and across the country. So no need to reinvent the wheel here. So
If there's no final questions, I think we will close the presentation. So thank you very, very much to Dr. Wong and to Kristin and to Mel for taking time out of your super busy schedules and being here with us this evening to chat with us about this very important topic of antimicrobial stewardship. So thank you again.
For having us.
Thank you. Good night, guys.